you have received dollars that you should not have received, thinking Medicare in particular. You have processes in place in terms of how you respond to researching those overpayments and making refunds. Well, in December, there was a proposed rule that was issued, and this came out through the Medicare program, but I have to honestly say, I think this topic was kind of hidden. It was hidden because this was a proposed rule that the title was CMS Policy and Technical Changes to the Medicare Advantage and Medicare Prescription Drug Benefit Program for calendar year 2024. With a title like that, I'm not thinking I'm going to read that rule and find anything related to Medicare Part A and B, because Medicare Advantage is Part C, Medicare Prescription Drug Benefit is Part D. So why am I going to suddenly find something about Medicare Part A or B? Comments on this rule were due the middle of February. I'm going to share with you a couple of the comments that were submitted after we talk about what was done. However, there were about 887 comments that were submitted, very few of them, unfortunately, having to do with this overpayments issue. What this proposed rule would do would be to modify the regulations for reporting and returning Medicare overpayments, and it would shift the language or remove the language of reasonable diligence and merely adopt the False Claims Act definition of an overpayment related to knowing and knowingly. This tends to have, from the way I read it, have an impact on your current six-month period for investigation of overpayment. This is the language that was included in the proposed rule. It would change the language for parts A and B. It would also be changing C and D so that everybody would say the same thing. But the current language is a person has identified an overpayment when the person has or should have, through the exercise of reasonable diligence, determined that the person has received an overpayment and quantified the amount of the overpayment. They would be changing that to say a person has identified an overpayment when the person knowingly receives or retains an overpayment. There has been this presumed 6-month period of time that you are assumed to have the opportunity to have researched and truly identified the extent of that overpayment. So this is what they are proposing to change. In terms of comments on this proposed rule, I did not go through all 800 plus comments. I looked at those that I thought would be more likely to have commented on this particular provision. But just this particular one is from a hospital association saying, going through a little bit of a history and the importance of that 6-month look back, but saying that previous CMS rulemaking on this topic, including the 2016 final rule on reporting and returning overpayments, appropriately recognized these practical realities and clarified that up to 6 months is permitted to conduct a necessary investigation and appropriately quantify an overpayment. HHS should not deviate from this current practice and impose an unrealistically strict 60-day deadline on hospitals and health systems to return overpayments. Instead, once a provider knows of the existence of an overpayment, HHS should allow a reasonable time frame for them to identify exactly how much they must repay before any 60-day clock is triggered. No judicial decision, certainly no statute, requires any change in CMS's existing approach. Another letter sent by a very large hospital system basically, again, addresses the current understanding of the rule and going in to say we urge the agency to avoid altering any regulatory language that could impact our ability to responsibly perform comprehensive compliance activities when initial overpayment is identified. So this rule is out there. It is proposed. It would sync up A, B, C, and D. But from a compliance perspective on your part, I'm very concerned that there is this potential that this actually stated, but well, often used 6-month period before the 60-day clock starts could go away. So, Michael, did you have anything on this?
No, I agree. I think that it'll be interesting to see in the end what the final rule says. I suspect, and I think a lot of this has come from some recent litigation with the Medicare Part C and the Advantage plans, where they've had some False Claims Act cases where some of the courts have said, that kind of lower standard of more of a negligence standard doesn't rise to the level of a false claim. The government in some cases appealed that, in some cases didn't. And so I suspect that that's why they've now proposed this stronger, definition under the overpayment rule that aligns directly with the False Claims Act. But as Kathy said, the practical effect of that, and when you go through the process of quantifying that overpayment, which, it took CMS 6 years to come up with that rule, but that process is really important. I think still, our message is always, even though there is, that reasonable diligence period to, start, you can't simply ignore problems, not that anyone would, but, that you still exercise reasonable, quick diligence in investigating these issues. But it will be interesting based on the number of comments and, based on, the practical effect of this, how much of a game changer it will ultimately be when the final rules come out.
And we will be monitoring this rule coming out. We know that, okay, I will say it this way. We know that we've got to have a final rule soon because of the changes that would be going into effect for the Medicare Advantage program for calendar year 2024. They need to have those fairly soon. But I wanted to say we'll know the answer to this overpayment issue as soon as they publish that final rule. But the way things have been going lately with CMS, they will say we're going to withhold this decision until a future, perhaps even separate rule. That to me would mean they've actually listened to comments and that they've read that maybe this is something they need to spend more time on. I think if they go ahead and respond to it as a part of this MA rule, we could have some issues. Just because if I looked at the comments, so many of them, again, 877 comments, fairly significant, but they were not focused on this issue. So concerning.
So much of the devil will be in the detail too. If they do release rules related to that, I hope that they include some extensive preamble comment that talks about, this time period to actually quantify something, and that they're not, essentially shortening this by such a significant amount of time where no one's going to have, a reasonable amount of time to investigate this. But I know that there's, on the Advantage side, so much litigation and questions as to whether these overpayment rules apply to those plans. So I suspect they'll come out with something. It might not be, as Kathy said, everything.
Yeah. Another thing that was included in this rule, thank you, Michael, they did include some proposals related to policies that have been, in my mind, an issue. Medicare managed care plan policies that have been a problem for you and your organization, particularly as you spend a lot of time looking at what is covered and not covered under fee-for-service Medicare, and then you get a Medicare Advantage patient and the Medicare managed care plan says, that's not our policy, this is the way we do it. What they would be doing if adopted under this proposed rule is that they would require your Medicare Advantage organizations to follow the coverage policies of fee-for-service Medicare that are outlined in your national coverage determinations, and even to some extent your local coverage policies. So recognize that this would be a major shift. and I think a positive for providers. And they would also be looking, and we're going to talk again in a minute about prior authorizations, but they would, this rule also addresses if a patient transitions into a Medicare Advantage product, perhaps they were either covered through an employer prior to transitioning, or they were covered under a different Medicare plan. That if they had an authorization for a period of time to receive a particular treatment or protocol, that would have to be followed by the new plan as well. So that again is a proposed rule. I think a lot of the comments that I have seen really focused on the Medicare managed care plans following the medical necessity determinations of fee-for-service Medicare. But I think this one related to the prior authorizations is also a positive from a provider and from a patient perspective. Any questions on that rule or proposed rule? Let's jump over to the No Surprises Act. In December, we had a couple of frequently asked questions that were published. One was very positive from a provider perspective because we were all dreading the requirement as of January 1 in issuing a good faith estimate to a self-pay patient of giving, including the downstream providers, any co-providers include in that estimate. CMS has said in this FAQ that they will be putting indefinite enforcement delay on that provision so that you are not required to provide a good faith estimate for downstream providers. They hope to establish an interoperability standard. Think from a business office perspective of your 835, 837, the transmission of information, that they hope to establish a standard for providing this information between providers and between provider and provider and provider and payer. So this isn't going to happen tomorrow. There is another proposed rule related to interoperability standards that came out in December as well. Just not going to be something that we have overnight, not going to be adopted quickly. There was also an FAQ that was published end of December, and it was for those providers who offer sliding fee discounts, particularly aimed at some rural clinics. My problem with this is, at least from a clinic perspective, where you might be using a charity care policy or a write-off policy that's based upon income, and that you're sliding, you charge $100 for a service, but if your income is within this level, you're going to get a 50% discount. If your income is at this level, you get a 70% discount. And then if your income is over a certain threshold, you're going to have to pay the full $100, that kind of thing. What I did not like about this FAQ was that it actually showed a draft a form or format that you could give the patient that detailed out your charges and then said, based upon income levels, this is the amount that you would owe for these services. And then at the very bottom, it had the federal poverty guidelines based upon family size, and it essentially listed from 1 to 10 individuals. I thought it was a fairly complex format, particularly for providing discounts on multiple services. So it is something that I urge you to look at. If you use a sliding fee, figure out how it would work within your organization to actually provide that to a patient. It bothered me in terms of the complexity, but that was just perhaps, not knowing your systems as well as you do. Finally, well, not finally, but on the No Surprises Act, the other thing that they did, they published these 2 rules that are supposedly fairly positive for providers, but then they turned around and they modified the independent dispute resolution process in terms of the amount of money that it's going to take to file an independent dispute resolution, where the fee previously was $50. It has now gone up as of January 1 to $350. Now, if I'm a hospital and I'm arguing on an inpatient claim, the amount that I was paid, and perhaps my reimbursement dispute is thousands of dollars off, paying this $350 is one thing, because perhaps I'm looking at it from the single claim perspective, perhaps a diagnosis related group perspective. I'm not arguing each and every line on the claim. In the case of a hospital outpatient service or a physician service, when I actually have to dispute the individual service, this is going to start to add up. And it dawned on me in a scenario that was raised recently by an emergency room physician, how this $350 adds up. This emergency room physician saw a patient, obviously in the emergency room, is not able to balance bill the patient. He is out of network, not able to balance bill the patient. But was also unhappy with the amount of money that he was paid from the insurance company. He was out of network. He appealed at a claim level, paid the $350, which is a significant amount of money if you're looking at a claim for emergency room services. Came back with a response from the IDR entity. So it has gone through negotiation with the payer. The IDR entity comes back with a question. What was the DRG associated with this visit? Mm-hmm. Well, an emergency room encounter does not have a DRG associated with it. It's an outpatient list service. The physician replied, there isn't a DRG. The patient was treated in the emergency room and discharged. The IDR entity comes back and says, well, then you must appeal each line on the claim, not the overall claim itself, but because each line on your claim had a different CPT HCPCS code, each one of those items must be appealed separately. Now I'm getting into $350 per line item on my claim to appeal it, many of which the charges were nowhere near $350. So this physician is really out of luck in terms of being able to appeal the claim at all, when we're suddenly looking at a $350 fee for each and every line on his claim. So concern about where this is ultimately going to go. To me, an act like that just basically says you're not going to be able to appeal physician for very much going forward. We also had a decision in February. I will say that the Texas Medical Association has appealed several different things related to the independent dispute resolution. They have been successful so far. Decision number 3 comes out for the Texas Medical Association in favor of TMA, and this was essentially going back to the decision that was made last fall that said essentially the dispute resolution entity was to look at the qualifying payment amount provided by the payer, and then look at what would show, what information provided by the provider would show that the QPA was not the appropriate rate. Well, the decision of the court said that you've already you've prejudiced the decision, because it is a decision that is being made starting off with something in favor of the insurers. And therefore they have set aside that rule. We are now waiting for a new rule to come out on the IDR process and how the IDR entities are supposed to make a determination moving forward. They did come back, CMS did announce that you as a provider should continue to submit claims under the IDR process. However, they will be sitting on them, and that they will not issue any final determinations on those disputes until additional guidance has been issued. But the clock is still running on you if you have a dispute and you need to file a dispute with the IDR entity. So not sure that that is really the way it should have gone, because in order to file, you got to pay your $350. But they are saying that, yes, you do need to move forward, file your disputes, and keep up with your timeframes. Although their time frame to issue a timely decision within 30 days, that is no longer in place. Michael, anything on that one before I jump to the last item I had?
No, I don't have anything else.
Okay.
Thank you for that.
And then last but not least, on prior authorizations, again, another rule that was published, and this one was published again in December. It was a busy month. Some people were trying to do Christmas shopping, but then CMS kept getting in our way. Comments on this particular rule are due today. This is going to be one that will be interesting. I will be interested in following the comments that are submitted. But basically it applies to Medicare Advantage, Medicare Advantage, state Medicaid programs, and Medicaid managed care. And one of the issues that I hear so often from providers is that they had to get a prior authorization for a service for a managed care individual, and they had to wait. They did not, there's no time frame established for issuing an authorization. This rule essentially would establish time frames for prior authorization requests, stating that no later than 72 hours after the request, if it is an expedited request, or 7 calendar days if it is just a standard request, the plan would have to come back with a response. I thought the fact that they said 7 calendar days was really interesting, because usually we see things that are business days, but in the case of these requests for authorization, they are looking at calendar days, at least right now in the way the rule is proposed. They are stating that the payers would be required as a part of their decision on that prior auth. If they decide to deny authorization, they're going to have to provide a reason, and that will go not only to the provider, but to the patient. That will be interesting. And then last but not least, they are actually considering offering some sort of provider incentives if you make these requests electronically. So we don't know what those incentives would be. They basically are saying this is something we are considering. Don't know if it's financial or actually modifying the time frame, so that if you requested an authorization electronically, would they speed up the clock on the issuance of those authorizations? So this is one, again, comments are due today. It will be interesting to see when we get a final rule. But hopefully not too far in the future, because getting these authorizations issued for providers is pretty significant, something that we need to have done. So with that, I'm going to stop sharing, ask if there are any questions. And sure, she says, I'm going to stop sharing. There we go.
Thank you, Kathy. If we have any questions, if you'd like to ask those, or put them in the chat box, I will certainly relay those on to Kathy and Michael.
And if you have something beyond anything regulatory that you want to ask real quick, glad to do it, particularly with Michael here. Then I think it's Susan and Jason time.
Great.
All right. Go ahead,
So
Susan.
Jason, I'll kick us off and then hand the baton to you.
Sounds great.
Hi, everybody. I'm Susan Thomas, and I am a senior manager at PYA. And we are really lucky today to have Jason Harden with us to demonstrate a really helpful analysis of open payments data that will really kind of allow you to see just the utilization of that information. And as you all probably know, the CMS Open Payments database is a public source of information, and it collects information from drug and device manufacturers regarding payments that those companies have made to physicians, mid-level practitioners, as well as teaching hospitals, and researchers. So when a company does anything of any type of a payment, and that can include, payments for a meal or traveling, consulting, some type of royalty, anything like that. So when the company makes that payment to a provider or a teaching hospital, they have to go and record that payment in the Open Payments database. And this was a result of the Sunshine Act that Congress legislated a number of years ago. So the fun thing about it is that this, as I said, this information is publicly available, so anybody can go out and look at it. And there's a number of ways that you can search for it. And then what Jason is going to demonstrate for you is how he has been able to take the database and fashion it into a tool, more of an interactive tool that can be used for analysis. So just think about this information that is available, and it's not only available to you, and all your, hospital administrative staff, but, honestly, anybody can look at it. A patient can go out and look at it. And ultimately, it's the responsibility of the provider to check the data to make sure that what is reported is, they agree with. I would probably venture to guess that not very many providers do that. But the data is collected for a calendar year. And then by the end of March, that's the deadline for the companies to submit this information to CMS. CMS then allows providers to go in and review and dispute or, make any kind of comments related to the information that's been entered. And then they are mandated by June 30th to CMS has to publish that data. And that's when Jason goes out and grabs it and works his magic with it. So this information is really key for compliance professionals when you're doing conflict of interest, and you want to make sure that what your physicians, your mid-levels, what they're disclosing to you when you go through that process is accurate, and they have, truthfully disclosed to you all of these outside financial arrangements. So it's a great check and balance for that process. There's some alarmingly high payments that go on, and it's really important for you, if this impacts any of your medical staff, that you're aware of it. Probably the most significant issue that can come up with providers receiving these payments is an impact on their medical decision making. And if you think about it, if a physician is getting paid hundreds of thousands of dollars from, let's just say a device company to do quote unquote consulting or speaking, then you really need to take that into consideration and make sure that that is not impacting the provider's, his order history, what kind of procedures they might be performing, just the medical necessity of the procedures. It can be very devastating, and there has actually been some enforcement in this area related to inappropriate use of medical devices or drugs, and then they tie that back to receipt of payment from a company. So At this time, I'm going to turn this over to Jason, and he is going to demonstrate how he utilizes the data, and also talk a little bit about how he's been able to work with different organizations on kind of harnessing the power of this data. Jason, take it away.
All right, thanks, Susan. Let me share my screen and we'll jump into the dashboard and just show some examples of what we found useful. Feel free to follow along in the chat. I have a link to the dashboard, the same dashboard that we'll be viewing. So feel free to click the link. I will share my screen. All right, here we have the dashboard. So we have a sample. This is actual data. We would have physician name, but since we made this a public dashboard, we decided to de-identify physician names. So instead of Dr. Smith, we have physician 445, for example. So what you see here is the Sunshine Act data, open payments data. We have 4 years of data from 2018 to 2021. That would be the most recent data until we get to June to get the 2022 data. As Susan mentioned, you can find this for a particular provider just by Googling open payments, and you can put in that provider's name or NPI. That's helpful, and it's easy to get to. What we found was the real challenge is aggregating the totality of those payments for a physician group. So in this example, we have 665 physicians, and understanding the total payments, it would take a long time to get to the $8.4 million throughout this 4-year period. Also, when you aggregate the payments, we're able to see by device manufacturer or GPO, device or drug manufacturer, the aggregate payments that are going to physicians for that specific organization. So we found that useful to aggregate the data in that manner. So I will just go through some examples of the functionality of the dashboard, and feel free if you have any questions to fire away. All right. So 665 physicians, this now includes mid-levels, so this would be all providers, 488 distinct manufacturers or GPOs, and as I mentioned, $8.4 million in aggregate payments. A number of filters that we have here based on payment type. So the 3 types of payments would be, or 2 types of payments, general and research. You also have ownership. Ownership is the ownership interest as of that point in time. So that could change, obviously, over time. But the reason that that is not selected on default, because when you mix that with payments, it looks like it's actually dollars paid or received, and that would not be the case. Filter by specific physician, specialty. If we wanted to look at a particular manufacturer, we would have the ability to do so. And then year, state, and then the nature of the payment. So when they submit, drug and device manufacturers submit the payment detail, they have to note the nature of the payment. So this could be cash or cash equivalent. It could be a consulting fee, education, entertainment, gift, royalty or license, travel and lodging, etc. So we'll start by looking at aggregate payments by physician in descending order. So we see that throughout this 4-year period, physician 445 has received $710,000 of payments. So what we're going to do is drill into this further, and then we can see the manufacturers that make up these payments over a 4-year period. We can see at the top, we see Acadia Pharmaceuticals. So you have $254,000 to this one individual physician throughout this 4-year period. The next question is, what were the payments made for? So let's drill down one level further to look at the nature of the payment. So we can see that the majority of these payments were resulting from consulting. So $202,000 related to consulting fees, $39,000 compensation for services other than consulting. So this could be speaking, continuing speaking, anything but continuing education, travel and lodging, food and beverage. So we'll drill back up. A similar view, but seeing this over a period of time, we'll see physician 445 again. So the same detail, the $712,000, but you can get a sense by year of what this looks like. So from 124,000 to over 200, down to 160, and then you can see that the summation of those payments. And then we can get to the same detail we looked at previously. So if you wanted to see for Acadia Pharmaceuticals, that timeline of payments, we could see what that was related to. Any questions so far? Okay. So using the same detail, rather than aggregating this detail by physician, we're going to aggregate it by specialty to see if anything pops out. Maybe we don't have an idea of where the payments are going by physician. Well, if we did it by physician, we certainly wouldn't know until we have specialty. So this particular client provided specialty, so we could look at aggregate payments in that manner. So you can see neurology, medical oncology, and gastroenterology are the top three. To drill down into this, if I want to look at medical oncology, for example, I can see that there are 3 physicians that rise to the top: 659, 462, and 155. I can then drill down further and see what this was related to. It's Insight Corporation, Seattle Genetics, and Celgene. And then the nature of that payment. The last view we're going to look at is payments by manufacturer. So we looked at payments by physician, payments by specialty. Now we're going to look at aggregate payments throughout the 4-year period by manufacturer. And we can see in descending order, Merck is at the top, AbbVie, AstraZeneca, Nevro. To drill in, we may want to see what physicians are receiving dollars from that particular manufacturer. Then we have the ability to do so. The same detail, similar to what we looked at by physician, we're able to see this over the 4-year time period by manufacturer. A few things to note that we found helpful outside of this is the time saved and the insight you have into if these payments could be influencing purchasing decisions, perhaps. Some tests that we've done are matching up accounts payable detail by manufacturer to the sheet you see here to see, is there an increase in any of the payments or purchasing decisions that are made for these manufacturers, to see if maybe there could perhaps be a correlation between the payments and the purchases made by the organization. One other thing to note that we found useful is matching conflict of interest disclosure detail to this data. So physicians are required to submit conflict of interest disclosures, but there's not a great way to determine if they're accurate other than have they been completed, and then is it for the appropriate amount. So what we've done is taken conflict of interest disclosure data, merging it with the open payments data, for instance, to see Dr. Smith had no conflict of interest disclosures submitted, but we see $200,000 of open payments. Well, maybe a conflict of interest disclosure has been missed. Or another scenario is it could be for a lesser amount. Maybe it's $20,000 is the conflict of interest disclosure, and we see an amount that's much greater than that. Just helpful to be aware of to make sure that the conflict of interest disclosures line up with the actual data submitted by device and drug manufacturers. So that is it. Feel free to check out the demo dashboard that I provided a link to, and any questions you may have, feel free to ask.
We have any questions for Jason or Susan? Again, you may ask those live, or if you would like to put those in the chat box. Jason, I'd be curious if you could do a quick search for the state of Nebraska, just to see what is available.
That's easy enough to pull. I mean, we have 7 years of the most recent data for open payments. I don't have that in this example that I have up here, but I would be happy to share that.
Sure. Any questions for Jason or for Susan?
I do have a question. I'm sorry, this is Christine. Did you import all that data and then manipulate, or are you doing it on the website?
Yeah, that's a great question, Christine. So we import the national data set that's published each June into our data warehouse. And then what we do is we'll match a physician roster that would have NPI, physician name, specialty, department, any other fields that we would like to track in the dashboard, and then we're merging those two data sets together.
Okay. Is there a way to do it in the dashboard, or is it you always have to manually import and then work it separately?
That's been the most efficient manner to do that,
Okay.
rather than having it in the dashboard. What we've built, it doesn't take long to import that and then connect based on NPI to match those records. And then you have the entire timeline of the payments from all the data that we've imported.
Thank you.
Yeah, you're welcome.
Susan, haven't you worked with this with some of the hospitals that you've audited and like that?
Yeah, absolutely. So we've seen facilities use this information in a couple different ways. Obviously, we've worked with a few organizations that have referred kind of their process to Jason to have him do like what he mentioned, like that match between what's in open payments and then bumping that up against their medical staff roster to get this level of interactive detail. Other places have incorporated a check of open payments for, you know, as part of their conflict of interest. They, you know, depending on what the provider discloses, they'll just go out and do a manual check of open payments. And you know, that can be successful. It does add some more steps to your process. So, you know, either way, if you do it, you know, just a manual, like one-off check, or if you do something more like this dashboard, both can be successful. It really depends on, you know, how you want to be able to look at the data and manipulate it and analyze it. Is, you know, going to kind of determine your approach. But obviously, you know, when you have a physician that has just these really high amount of payments from a particular company, you really want to look into that and, you know, look at their prescribing patterns, look at their, you know, what kind of procedures they're doing, just to make sure that those payments have some validity to them and they're not impacting patient care.
And in some way or other, this allows you to then validate what the physicians have reported
Yes.
for their conflict of interest. This gives you a way to validate, is that correct?
Yeah. And so as part of your conflict of interest process, and if you notice there's a huge discrepancy between what was put into the open payments database by the company versus what the provider reports back to you, you need to talk to that provider and say, you know, you only disclose that you received $10,000, but open payments has that you've gotten $150,000. So, you know, you want to be able to reconcile any differences between what they've disclosed and what has been reported, you know, by law into the open payments database.
Very good.
Thanks,
Any other
guys.
questions?
Well, thank you.
All right, thank you all.
Thanks.
Thank you both. Okay, next on our agenda, Rachel Anderson from PYA is going to give just a quick overview of some federal signage requirements. And I'm going to provide a very short overview of Nebraska's signage requirements. So Rachel, I'm going to turn it over to you first.
You're muted.
How's that? Can you hear me?
Much better.
Okay. Are you getting an echo too?
No.
Okay, good. Sorry. Share my screen here. Okay, so I have this document that I created. It has the specific document that's required to be posted, who it applies to, a brief description of the document, including a hyperlink to the regulation that speaks to what's required. And then if it needs to be posted on the website, a conspicuous location, or just a standard notice. So we can scroll through here. And like I said, this includes everything that I could find that was required from the federal point of view. Let's see, for example, I have FMLA stuff in here, EMTALA, good faith estimates and all of this has been updated as of February, and the hyperlinks will take you to the website. So as things change, you should go right to the new information. Any questions about this?
I'm just going to ask you to demo. Would you click on something?
Absolutely. So for example, I'll click on the moons here. And of course, it's not working. There we go. So it takes us right to the moon.
And that was a good choice because that's one of those that you have to change by April 27th.
Perfect. And I'll open this up. So this is the most recent moon, or the updated moon. And you can see on the bottom here, it has the expiration of November 11th, 2025.
And for those who aren't familiar with, go ahead. I was going to say, for those who aren't familiar, when I said the updated moon, what is it, Rachel? Important message and the discharge notice?
Yes.
Those all have to be revised by April 27th because in the footer, way down at the bottom in the fine print, they've added non-discrimination language. So you need to get the new forms in place by April 27th. You can use them sooner, but
thank you.
I love the fact that you clicked on the moon to share.
And we did have a question about whether this would be available to everyone, and we certainly can make it available to you. So everybody will have a copy of that with the links, the hyperlinks. Any questions?
John, I will email it to you, and then you can disperse it from there.
And from a compliance officer perspective, get prepared, put on your comfy shoes, start wandering the halls. Because you've now got a checklist of what should I have posted. I mean, there's some things on here that obviously are website posted, but others are signage or materials that you're handing to patients. This gives you a good tool to actually wander around and see that your team is meeting the requirements.
Oh, here's one, Kathy, I did want to point out, especially with being critical access hospitals, making sure you're posting your physician availability.
Super.
And that's a great segue for me to share what is required in Nebraska. So the Nebraska Hospital Association has been compiling this for a few years and adds to it and updates it. So I'm going to share my screen. Can you see the required signage page?
Yes.
Yes? Okay, great. So I will put the link in the chat to this, but this is out on the NHA website. So this is what we have requirements for in Nebraska, and there may be a little bit of overlap with what Rachel talked about. But LB 913 is the assault of a healthcare worker. So you can get it in portrait or landscape, and then in Spanish. So I'm just going to click on this first one and take a look at it. So obviously it's a PDF, so you can customize it to whatever you'd like for your facility, but that's the language that you would want to use. The others that I know are specific to Nebraska, the Safe Haven Act, this tells you where where things need to be posted. Some of these have hyperlinks, some of them do not, or it may just tell you where it needs to be. If there's something that there's not a link to it, you can just reach out to the NHA and they can get you copies of that. But we frequently get comments about the Open Meetings Act, things that have to be posted in your meeting rooms where you have board meetings. So this will give you, again, kind of a good list for Nebraska where all those things need to be made available. It's pretty lengthy. As Kathy mentioned, it's when you have to make that walk around to see what's out there and what's available, there's quite a bit. So, but I, again, will put the link to that in the chat box for you. And any questions that Rachel and I can answer for you?
I'd like to throw out that if there are folks who know that there's something else, they happen to wander the halls and see, why do we have that sign up? It's not on John's list or Rachel's. Please let us know. I mean, there's no telling if something was missed, but we'd like to keep both documents well up to date. I just think it's a good opportunity from this compliance group sharing when you suddenly find something out that is missing. And then, John, there's a question in the chat for you.
Question is, who is responsible for translation of the assault in Spanish? You've had some patient concerns. I guess I would need to follow up and see who translated that originally. If I can ask Jen, was the concern that the information was not translated correctly? Yes. I will follow up with the individual who compiles that for the NHA. If you could maybe send me an email and let me know what the specific language is, yeah, please reach out to me. I will certainly do that, and we'll find out and get that corrected. So.
And I will just throw this out. If somebody else happens to have that already translated, send it to John and to Jen.
Yes, that would be great. We only know what we know. So yeah, if there's something incorrect, we want to, looks like she did pay to have it changed. So yeah, but we'd love to have that corrected for everyone and to have that correct for all the hospitals and all the members. So thank you very much.
John, this is Kirk. I have a question. We actually did this last week at our facility. Question I have is a roster and surgical suites with privileges granted by medical practice. Can you expand a little bit on that?
Not sure I can go into a whole lot of detail because, again, just passing along the resource, but Rachel or Kathy, would you have any deeper knowledge on that one?
Which list was that on? Was that on Rachel's or on Nebraska's?
I believe on Nebraska's.
Okay, John, we probably need to go back and look at the state law that requires that.
Okay.
Maybe whoever developed it internally, let's see what you have when you click on that one.
Let me go back here. I'm sorry. And tell me again, it was the
roster and surgical suite with privileges. Right, the third, yeah, right above the estimate chart of the charges.
Looks like posted due to licensure and federal condition of participation regulations and our statutes.
Oh, okay, that's going to then go back, I think, to Rachel. We need to see where your asterisk goes, but Rachel, you did have the one that you called the attention to related to the posting of the availability of physicians for the critical access hospital.
Yes. Hang on and let me find that again.
And I think the the one policy that was referenced in Nebraska, it's in the hospital licensure rules, and that roster be maintained in the surgical suite.
Okay, different one.
Not that it be a public document or anything, but that it be a roster available in the suite where you delineate that particular surgeon's privileges.
Michael, does that mean it's sufficient to have it on our intranet that the staff could get to it?
That would probably be a question for the surveyors, but it says maintenance of a roster in the surgical suite. So I know these were written in 2006 before an electronic environment.
Right. That's why I was asking the question. We have it available on our intranet.
Mm-hmm. Has anyone in the group been surveyed specifically on that?
I've just asked the question, if it's on your intranet, is there access in the surgical suite itself? Their computer?
Yes. Yep. They have there's computers in all the OR suites.
Okay.
Several. There's actually a couple, 2, 3, for sure.
This is Chandra, calling from COZAD, and we had a survey and that question was brought up, and basically they told us that you have to have access to it, and for you to determine if that the surgeon has appropriate privileges to be doing what he's supposed to be doing. So if there was a question, you would be able to access that and determine it.
Yeah.
And we were surveyed back in August.
And were they at all with an electronic roster? I'm assuming most places that's what it is electronic, and nobody has a printed out list of privileges. I mean, some might, I guess, in a bound book or something, but.
Yeah, they were okay with either way. Obviously, for sterility, you would have a computer and there would be the easiest. But yeah, they said as long as you were able to have access to it to be able to check.
Yeah. Yeah. And so I think as long as that electronic access would be right there, or that readily available, like you said, if during a procedure, or if there was a question prior to the performance of a procedure or something with somebody's privileges in the OR, you'd be able to confirm that.
Chandra, did they ask you to demonstrate that you had access?
They did not. I will tell you that our surveyor was pretty lenient when it came to that. They just said, hey, make sure you can get access to it. There were other things that they focused on in the surgery area, so they kind of let us get by on that one because they were looking at other things.
Thank you. Thanks for sharing. And Michael, thanks for jumping in on that one.
Yeah, we'll certainly review that list too. If there's things that we can delineate that can be electronic versus posted, we'll make note of that on that list as well.
The other question I have is, I know this is a hospital, but if you had any information for private practice clinics, that'd be great as well.
Yeah, I don't know if Rachel, do you have anything related to private clinics?
The list that I included also includes things that need to be listed in physician clinics.
Okay.
Think about your signage related to No Surprises Act, things like that. So that would work from the federal side. I think from the state side, it would be literally looking at the statutes that would over the clinics.
Certainly the assault of a healthcare worker, that would be one that you'd want to have.
Again, if there are others who've developed things like this, please share.
Well, as exciting as signage is, I know everybody's anxious to get on to getting ready for May 11th, at the end of the public health emergency. We did send a link to you in advance with the suggestion that if you had a time available, there was a webinar that Marty had done. And so she's just going to give kind of a summary of this today. If you still have that link, if If you want to go back and watch the full webinar, you can certainly do that. It's probably a deeper dive. But Marty, I'll turn it over to you to kind of lead this discussion.
Can you hear me?
Yes.
Excellent. And my camera has decided, it's not an empty room that you're seeing there. That's my camera deciding that it's not going to cooperate. So we're just going to turn it off. You can see my picture. And can you see on the screen the PowerPoint? Or is it that strange notes version of the PowerPoint presentation?
No, you got your PowerPoint.
We got it.
Okay, just one, you've got, because what I see is the multiple screens, right? You're just seeing the one screen. It says getting
Yes.
ready for May 11.
Yes.
Excellent, excellent. Great. Well, good afternoon, everyone. We're going to spend a few minutes talking about the role of the compliance officer in helping your organization prepare for the end of the public health emergency. For those of you that have been in your position for at least 3 years, you remember fondly March of 2020 with the beginning of the public health emergency and the rapid fire release of guidance from the federal agencies regarding regulatory waivers and flexibilities to assist providers as they met the challenges of caring for a large population with COVID-19, as well as responding to community health concerns. And what we're going to, it is pretty overwhelming to look back at what we consumed during that period of time. So as we consider the PHE ending on May 11, after a mere 1,196 days, we can look back and remember that truly 3 years ago today, we began with CMS's publication of its Section 1135 blanket waivers and flexibilities. So this was the first publication from the federal government of CMS exercising its authority under Section 1135 of the Social Security Act to waive certain regulatory provisions and conditions of participation to accommodate providers during a public health emergency. This was the first time CMS had published such waivers of nationwide scope. Typically, these 1135 waivers are published in association with a natural disaster, such as a hurricane, when there is stressors on the healthcare system that require accommodation. But this was our first attempt by CMS to figure out how it was going to provide regulatory relief on a nationwide scale. It followed the March 13th publication with a March 30 publication addressing waivers of certain sanctions under the Stark Law. It's often misconstrued as, well, these are Stark Law waivers. In fact, none of the actual provisions of the Stark Law changed. Instead, the agency said we would not pursue enforcement activity for specific types of arrangements. Out of order, I apologize. On March 16th, our friends, the Drug Enforcement Administration over at the Department of Justice, published their authorization under the Controlled Substances Act to permit providers to prescribe controlled substances utilizing telehealth as opposed to requiring an in-person visit. Then over an extended period of time throughout 2020, we had a series of 4 interim final rules published by CMS. These interim final rules actually went in and made changes to provisions in the Federal Register. Provisions of the Code of Federal Regulations, So they actually changed the language of the regulations. So under the blanket waivers and flexibilities, it's a temporary reprieve from the enforcement of specific provisions. Here in these interim final rules, CMS actually changed the rules, including a specific provision that would be in effect for the duration of the public health emergency. On November 25th, then, CMS published its acute hospital care at home waiver, which permitted hospitals to apply to furnish acute care services in patients' homes within specific requirements. On May 5th of 2021, CMS published its ground ambulance services treatment in place waiver, although it was effective back to January 31st of 2020. November 4 of 2021 is when we got the interim final rule on vaccinations for healthcare workers. There were a number of guidance documents, primarily from OSHA, that predated this final rule, but this is what created the regulatory requirement as part of your infection control programs to ensure that your workforce had been properly vaccinated. That sort of draws the line on the formal rulemaking processes and formal waivers and flexibilities. On top of all of these provisions, we've also had some specific COVID-related provisions that have been included in the annual rulemaking process for all of the rules, from inpatient hospital, Medicare physician fee schedule, outpatient hospital, and the like. The Office of Civil Rights and the Office of Inspector General published in March of 2020 notices of enforcement discretion specifically relevant to the telehealth exceptions. The OCR notices of enforcement discretion concern the use of HIPAA compliant vendors for purposes of providing telehealth services and permitted the use of generally publicly available modalities such as Zoom, such as Teams, without concern for HIPAA compliance of those systems. The Office of Inspector General kind of followed suit on those notices, but also published a separate notice of enforcement discretion that has permitted us to waive Medicare beneficiaries' copays and deductibles for both telehealth services as well as virtual services. And then finally, there's just a series of federally frequently asked questions and other guidance documents that have been published by the agencies to provide more specific direction, application of the waivers in specific circumstances, for example, that have helped us over the last 3 years with these accommodations. Luckily, there is a single source of truth. You see the website here. It's the Waivers and Flexibilities website on a web page on the CMS website. It is really a series of links to all of the aforementioned documents so that you have one place that you know you can go to and access the most recent version of any of these documents. So that's our starting point. As we think of unwinding from the PHE, these are all of the regulatory actions that we have to evaluate to determine what, if anything, we need to do with respect to compliance. So CMS has begun providing direction soon after the announcement was made on January 30 of this year that the PHE would come to an end on May 11th. In fact, their first piece of guidance dates back to August of last year when they posted on their blog an article creating a roadmap for the end of the COVID-19 public health emergency. It was accompanied by a series of provider fact sheets that went into greater detail on the work to be accomplished in preparation for the end of the PHE. And then on February 9th of this year, we received our first very specific fact sheet. It's the COVID-19 Public Health Emergency Transition Roadmap. It's about a 12-page document. CMS followed up the publication of this document with a webinar to explain specific provisions within the roadmap. That recording of that webinar is available on the CMS website if you care to listen to that. At that time, they noted that they would be updating the specific guidance that had been published back in August for providers. And in fact, on February 23rd, CMS posted the updated provider-specific fact sheets. And those fact sheets probably are your starting point for a lot of the unwind work you're going to begin focusing on, specifically the provider fact sheet, the hospital fact sheet, as well as the physician practice fact sheet. Then on February 27th, CMS published the What Do I Need to Know CMS waivers flexibilities in the transition forward from the COVID-19 public health emergency. It is about a 7-page document, again, still at about the 10,000-foot level, not going into specific regulatory waivers and flexibilities, but providing a broader view of the end of the PHE. In releasing that document, CMS noted that between that point in time and May 11, it would be providing stakeholder calls and office hours to provide additional guidance to providers, and directed you to the CMS emergencies page, that website I previously cited, that it would be the source of continuous updates. CMS has in fact started doing this, because last week, or the week before, last week on March 2nd, during the Skilled Nursing Facility Long-Term Care Open Door Forum, they addressed the application of some of the SNP-specific waivers and the end of those waivers. So if you see the notices for those open door forums, pay attention, because those appear to be a vehicle that CMS is going to utilize for providing this guidance. Also last week, OIG posted on its website a notice talking about the flexibilities that it has posted relevant to the PHE and how those would be expiring as of May 11th. So lots of guidance documents out there available to assist you going forward. To that end, let's consider what's not impacted by the end of the PHE, and so things we do not have to be, of which we do not have to be immediately concerned. FDA emergency use authorization for COVID vaccines, tests, and treatments are not impacted. Any change will be as a result of the FDA taking specific action. Hospital long-term care facility COVID-related reporting requirements. As you know, the hospital reporting requirements are set to continue for an extended period of time, although in publishing that rulemaking that established those deadlines, HHS did note that it may elect to discontinue them sooner than the April of 2024 deadline, which is now in the regulations. The previously referenced healthcare provider vaccine mandates will require separate regulatory action. OSHA's healthcare emergency temporary standard, although OSHA currently has posted on its website a notice indicating that changes to that standard are in the works. And finally, any duties and obligations providers may have relating to their receipt of provider relief fund payments, those are not impacted. So those deadlines for reporting on your expenditure of PRF funds, those single audit requirements, and importantly, all of those duties and obligations you accepted as part of the attestation you signed at the time that you received your PRF funds remain in effect. In particular, if you'll recall, one of those requirements is treating COVID-19 patients as all being in network and not charging out-of-network fees or out-of-network charges to patients receiving COVID-19 treatments. So that's what we don't have to worry about today. So we're going to get into a little more detail on sort of the unwind process with regard to these topics you see here on the screen. The preview here is that Kathy and I have been working as diligently as possible in generating what we hope to be a useful unwind checklist. Unfortunately, that document remains in our internal QA processes, making sure we've crossed the T's and dotted the I's. We intend to release that checklist publicly on Wednesday. Kathy and I are doing a national webinar that day to introduce the checklist and to talk about some of these CMS directives we've just referenced previously. I'll be sure on Wednesday to forward a copy of that checklist to John. If any of you do want a copy of that, we'll be able to release that to you. So I apologize if there's sort of a disconnect between the date of this compliance roundtable and our completing the checklist for you. But hopefully these next few minutes will provide you with sort of a broad overview of what's included in that checklist. Again, checklist is not intended as a work plan. It is a checklist, meaning that it is intended to provide you with guidance on the specific areas on which you need to focus to make sure your policies and practices are going to comply with the post-PHE rules. And appreciate in a number of these areas, you've had significant staff turnover, and it's been 3 years. And so what was once normal is in fact going to have the appearance of a new normal as we go through this unwind process. So we'll start talking about these regulatory flexibilities here. Just a second. I'm not having the greatest luck getting this to advance. This is a whole new. That did not work. Sorry. My apologies. Oh, that button. There we go. Regulatory flexibilities. Specifically talking about hospital waivers and flexibilities. These fall into 3 categories. These are waivers that provided for expansion of your physical capacity to care for patients. They were waivers that expanded workforce capacity, and they were waivers intended to reduce the administrative burden to permit you to focus on patient care. With regard to physical capacity, to the extent that you expanded locations for the delivery of inpatient services, as of May 12, you need to retract, only providing inpatient services in the appropriately designated areas. If you have been providing EMTALA screenings outside of the emergency department, and certainly as we were providing testing and other types of screening for patients to expand our capacity, we were doing this in parking lots, we were doing this in cafeterias, wherever it may be. Again, we go back to those strict EMTALA requirements for the delivery of the medical screening examination within the defined emergency department. If you created any new hospital outpatient departments, or if you relocated existing hospital outpatient departments, again, we contract back to the pre-existing HOPDs, except to the extent you've gone through the formal process of their designation. Of note here is the permission CMS afforded to treat the patient's home as a hospital outpatient department. So to the extent you have hospital staff providing partial hospitalization services virtually to patients in their homes, as of May 11th, that will no longer be considered a reimbursable service. Note, however, importantly, that as part of the 2023 outpatient prospective payment rule, CMS elected to extend the ability to provide behavioral health services via telehealth to patients in their homes by hospital staff. That differs again. This isn't hospital staff that cannot separately bill on the Medicare physician fee schedule for those types of services, but in fact, this is hospital staff providing those services. The continuation of that will be permitted under that new HOPPS rule. One particularly challenging change will be the discontinuation of the waiver of the skilled nursing facility qualifying 3-day hospital stay rule. So pre-pandemic, if you wanted to admit a patient to a SNF, a Medicare beneficiary to a SNF, and you wanted that SNF stay to be covered, you knew that there had to be a 3-day qualifying hospital stay. Again, to manage capacity, CMS waived that 3-day requirement and has been covering SNF stays regardless of whether there has been a 3-day qualifying hospital stay. And for the most part, hospitals have utilized this without regard to whether the patient was a COVID-19 patient or not. Again, this changes as of an admission to a skilled nursing facility on or after May 12, 2022. When I referenced that SNF open door forum last week, this is one of those issues they clarified, that the rule would apply to admissions to a skilled nursing facility on May 12th or thereafter. The acute hospital stay at home waiver, if any of you are taking it, if any of you have applied for and received permission to utilize that waiver, that now will actually continue through December 31st of 2024 as a result of the Consolidated Appropriations Act of 2023. Specifically to our critical access hospitals, to to the extent that you have expanded your bed count to accommodate COVID-19 patients, again, you'll be back to the limitation of 25 beds. The average length of stay of the 96-hour average length of stay, again, that's been waived for the duration of the PHE. It will return on May 12. At this point, we don't know how CMS is going to calculate a 96-hour average, since this will be beginning in the middle of the year, but wait for some guidance to be coming from CMS on that particular point. If you've established any non-rural offsite surge locations, again, those will need to be discontinued. Regarding that second category of waivers and flexibilities, expanded workforce capacity, we will return to the normal rules regarding medical staff credentialing and privileging. There have been some exceptions that have been put in place during the PHE so that we did not have a gap in privileges that would in any way interrupt with physicians or non-physician practitioners furnishing services in the hospital. The requirement that all patients be under the care of a physician will return for PPS hospitals. And the CRNA supervision requirements will again be in effect. They have been waived again during the PHE, but they will return. With regard to reducing administrative burden, there have been some broad exceptions with regard to the quality assurance and performance improvement and the utilization and review conditions of participation. Those, while the core program remained, these waivers impacted the scope of the program, the frequency of certain activities within the program. Certainly the individuals responsible for these programs within your organization need to be well aware of the return, again, to the normal requirements within the COPSs, within the COPS. There are a number of discharge notices that have been waived for the duration of the PHE, specifically with regard to providing information to patients regarding post-acute care options. Again, those will return for patient admissions on or after May 12. And finally, the rules with regard to verbal orders and order sets and the authentication of those rules will return to the pre-PHE rules as well. That's just a sampling. In fact, I think if I counted, there were well over 40 provisions specific to hospitals in these waivers and flexibilities. But these, I think, are sort of the core requirements most likely to require your attention and may involve some significant work to return them to normal processes. On the physician side of the house, one accommodation that had been made with regard to provider enrollment during the PHE was the waiver of the requirement to include on a physician enrollment form their home address if in fact they were delivering telehealth services from their home. I mean, the general rule for enrollment forms is you have to include any location from which you will provide services to Medicare beneficiaries. CMS appreciated that the MACs would be overwhelmed with amended enrollment forms if in fact they required the home address to be included on the forms. So thus we were not responsible for accomplishing that during the PHE. CMS has now put us on notice that in fact, if you do have providers that are furnishing telehealth services from their homes, they will need to amend their enrollment forms by no later than the end of this year. The other important physician waiver regards direct supervision of services performed virtually. During the PHE, any service that required direct supervision, that could be accomplished via audiovisual connectivity, as opposed to having the physician physically present in the same suite of offices and immediately available to provide assistance. CMS, in last year's Medicare Physician Fee Schedule final rule, agreed to extend the virtual direct supervision rule through the end of this year. If there is no change as a result of the 2024 rulemaking, then we will go back to the physical presence requirement at the beginning of next year. Also, just of note, back to the issue of the Stark Law waivers, and again, remember it was a waiver of the enforcement of certain provisions. Appreciate there may have been financial arrangements that were entered into your positions during the height of our financial distress in March, April, May, June of 2020, accommodations made to positions, which may or may not still be in place, but appreciate that CMS and OIG have been very clear that as the PHE terminates, so must any financial arrangement that relied on a Stark waiver would need to be returned to the specific compliance with the Stark exception, and specifically the agencies have called out the fair market value requirements within those exceptions. Also, OIG has provided a vehicle for providers to pose specific questions to allow certain arrangements entered into for purposes of accommodation during the COVID-19 pandemic. There's about 19 of those questions that are posted on the OIG website. The OIG has made very clear again that any reliance on that guidance offered by OIG will terminate as of the end of the PHE. Let's talk about telehealth briefly. Are we doing okay on time? I just want to check with the group if we need to speed up, if we don't want to go into this level of detail. Are we doing okay? Anyone?
It's okay.
Okay, we're all doing okay? Great. Okay. On telehealth. Probably well aware the Consolidated Appropriations Act of 2023 extended a number of the telehealth flexibilities that were put in place early in the PHE. Those will continue through December 31st of 2024. So as we've been providing services and billing for them on the Medicare physician fee schedule, or for RHCs and FQHCs, we've been billing for those telehealth services. That's going to continue through the end of 2024 with some exceptions. And these are specific areas where we'll be looking for rulemaking from CMS. Through the course of 2020 and in fact continuing through 2022, CMS expanded the list of approved telehealth services. So we went from about 100 services defined by CPT and HCPCS codes that could be furnished via telehealth and be reimbursable to about 240. CMS decided in last year's physician fee schedule rulemaking, it would begin pulling back from that list. It identified certain services as Category 3 services, and it intended to allow those to be continued through the end of this year, end of 2023. All the other services that were expanded, the non-Category 3 services, CMS intended to discontinue coverage for those services as of 151 days post-PHE. If we recall, that was the prior expansion of telehealth coverage under the Consolidated Appropriations Act of 2022. CMS has noted that it will work on this issue through the rulemaking process. So we hopefully don't have to concern ourselves with sorting sheeps and goats in terms of the specific telehealth services that main list will remain primarily intact through the end of next year. The payment parity issue is significant. For independent physician practices, they have been reimbursed at the non-facility rate for telehealth services. Pre-PHE, telehealth services were reimbursed at the facility rate. And the question, CMS said it intended to revert back to the facility rate across all providers as of the end of this year. We'll have to see what it chooses to do going forward. I referenced previously, OIG had published a notice of enforcement discretion permitting providers to waive copays and deductibles for telehealth and virtual services. OIG last week posted its notice that notice will terminate at the end of PHE. So if you've been waiving copays and deductibles on telehealth services, you must discontinue that practice. And finally, also, OCR noted that it would, it had provided prior guidance indicating at the end of the PHE that in fact providers will need to use HIPAA-compliant telehealth vendors. So its prior notice of enforcement discretion also will terminate. That's not the end of the telehealth story, unfortunately. Beyond just the expansion of Medicare coverage under the physician fee schedule for telehealth services, CMS afforded a number of accommodations to replace what would otherwise be required face-to-face visits, to permit those to be performed virtually. As you see here, and I'm not going to even begin to go through this list, those terminate to varying degrees with the end of the PHE. So if you've been, for example, if you've been using telehealth to perform face-to-face visits for home dialysis patients, that those are specifically required in the regulations for home dialysis and reimbursement for home dialysis for Medicare beneficiaries, those will go back to being face-to-face visits effective on May 12th. So again, need to kind of do a deep dive into these different areas, see how they've been utilizing telehealth, making sure that they go back to the required inpatient visits. Let's talk briefly about controlled substances. As we referenced previously, during the PHE, under the authority granted to the DEA in the Controlled Substances Act, the agency has waived the in-person visit requirement, and thus permitting prescribers to prescribe a controlled substance based on a telehealth visit if there was no prior face-to-face encounter between the prescriber and the patient. That will terminate at the end of the PHE. In fact, because the DEA has no legislative authority to continue that waiver past the end of the PHE. What the DEA does have is authority under the Controlled Substances Act to create another exception, a separate exception, to permit the continued use of telehealth to prescribe controlled substances. And in fact, on March 1st, DEA released a proposed rule that would expand the ability post-PHE to prescribe controlled substances without a prior face-to-face encounter. The proposed rule is narrow. It only permits those telehealth prescriptions for schedules 3 through 5. So no Schedule 2 prescriptions following a telehealth visit only. Also, DEA proposes to limit the prescriptions to a one-time 30-day supply. And thereafter, you could not prescribe any controlled substances for that individual without a face-to-face visit. So note that the comment period on this proposed rule is short. It's only through the end of the month. Clearly, DEA wants to have a new rule published prior to the end of the PHE, certainly appreciating the disruption the end of that telehealth prescribing rule would permit, but certainly something worth comment on if this has been a challenge in your practices. Very briefly on COVID-related reimbursement, and you'll receive a copy of the slides. The only one I want to focus here, there's coverage for COVID-related vaccines, how that will be impacted by the end of the PHE, COVID-19 testing, but let's focus on payments for COVID-19 treatment. Most importantly, your hospitals have been receiving a 20% increase in DRG payments for COVID-19 inpatients. That will terminate with the end of the PHE. We'll still need some clarification from CMS when exactly it terminates. Is it only for admissions on or after May 12, which is what we suspect, but we'll certainly need a clarification. But that has some pretty significant financial impact for a number of hospitals, especially those that are still seeing inpatients with COVID that have a COVID-19 diagnosis. You're also going to see an end to the separate payment for drugs and biologics that have been approved for treatment of COVID-19. Instead, now it will just be included, those payments will be part of the package for the APC. And so that, again, could have a significant financial impact for your hospitals. Briefly, let's hit on Medicaid redeterminations. States received as part of the financial relief that states were afforded by the federal government during the PHE. There was an increase in the FMAP. So the percentage of each Medicaid dollar that is spent, what percentage is paid for by the federal government versus what's paid for by state government. That FMAP percentage is unique to each state, but during the PHE, it has increased by 6.2% for all states. The trade-off for that has been a state must agree not to disenroll anyone from Medicaid once they qualify. So individuals who met the income requirements back in June of 2020 have been able to remain as a Medicaid beneficiary without regard to any changes in their income. With the end of the PHE, the federal government will begin stepping down that FMAP percentage increase, as you see on the screen, until the end of this year. We'll be back to no FMAP increase for any of the states. As part of this, CMS has mandated that states complete redeterminations within a year. So beginning April 1, states will begin the process of reviewing eligibility for all Medicaid beneficiaries to determine whether they continue to comply with income requirements. A great deal of research around this. What's the potential impact? Kind of seeing somewhere in the neighborhood of about 5 million individuals are likely to become uninsured through this renewal process, meaning they're not going to be eligible either for employee coverage or they're not going to be eligible for exchange plans. How this potentially could impact you if you've been patients that have had Medicaid coverage, if they are disenrolled from the program, there's a likelihood there's not a likelihood, a potential they could return to being uninsured, certainly having a negative financial impact on your organization. So you have an interest in communicating with Medicaid beneficiaries that there will be this redetermination process. They will be contacted to verify information, that they need to respond to those requests of information and ensure they maintain their Medicaid coverage. So that is a pretty quick and dirty overview on where we are with the end of the PHE. If we have any questions, be happy to give it a try. Appreciating that still a lot of unanswered issues we'll need to be addressing with CMS and the other federal agencies.
Thank you, Marty. Wow, a lot of information. Any questions from the group that anybody has for Marty? Again, jump in, or you can put it in the chat box. Marty, if I could ask, when you did the webinar earlier, what questions were asked from that audience? Maybe there might be some things that were brought up on that call that could be applicable to our group today.
Oh, goodness, Kathy. There were a lot of questions around controlled substances. That is an area of significant concern, and questions about the DEA proposed rule, which published 2 days before the webinar. So we almost got it read, but what's new, right? A lot of questions around the SNF 3-day stay, because that was before there was the clarification from CMS and that open door form the next day.
I'm thinking about what I responded to, and unfortunately, these things kind of blur together sometimes.
They do.
Let's just skim the list here.
Sorry for putting you on the spot.
Yeah, actually, thanks a lot.
Well, I think as Kathy said, they blur together. That slide that had all of those telehealth flexibilities that would discontinue, that slide was generated based on questions we got during the webinar. Because we went back in and kind of, went line by line by line in the guidance to figure out what would continue and what would not continue. Because again, the challenge you're going to face is the original source documents are sort of all over the place. I mean, there's not just, yes, there's a website that's the source of truth, but it's the source of truth insofar as it links you to other documents. And so it's figuring out of this literal page-long list of documents which are relevant to a particular waiver or flexibility. And that's the process we went through to generate the checklist. Again, unfortunately, don't have complete yet to share with you today. But an example of that was these telehealth flexibilities.
And
because
one that I just pulled up, Marty, was telehealth for a Medicare Advantage beneficiary.
Right, right. Because the beginning in 2020, CMS afforded MA plans greater flexibility to provide coverage for telehealth. So they did that in 2019 for plan year 2020, and then the world changed. So most MA plans have followed the traditional Medicare coverage rules with regard to telehealth. Though that's likely then we're going to see some divergence now with regard to coverage. Again, after we get through this extension period in 2024. And then I think we had a lot of questions around the payment parity issues, the list of covered services and the like. But that's just CMS has stated, and it's on the waivers and flexibilities webpage, that they will address that through the 2024 rulemaking process of the Medicare physician fee schedule. So hopefully we won't. The concern has been there's a list of pretty common telehealth services like cardiac rehab, for example, that's not a category 3. So by the current regulation, Medicare coverage for those would terminate like October 9th, I think was the date. And so there's a gap, right, between October 9th and the beginning of the next calendar year. And so what's CMS going to do in that rulemaking process? We don't have an answer yet.
And one of the questions that I just remembered, Marty, and therefore I put in the chat, is a question that someone had raised related to what about the waivers that are state specific that were adopted by their Medicaid plan, and what are they, that kind of thing. I've just put into the chat the link for the state Medicaid plan amendments that they did for the public health emergency. You need to be monitoring your state website to identify what they're changing. Marty addressed the redetermination requirements for coverage of Medicaid, but where they implemented new programs or changes, what's continuing, what's not, when do they phase out? That's something that for some of this, when it was not a federal waiver, but it was a state specific waiver, you're going to have to check your state's website. And I'm sure that NHA is also providing that information.
And again, that Source of Truth website, that CMS emergencies website, has links to those documents by state as well. There's 2 sources you can go to get it. And any waiver that was granted by CMS to a state Medicaid program, those will terminate at the end of the PHE. The question is, did they terminate earlier because they were dependent on a state declared emergency? And what we're seeing is it's all over the map. Some states have completely gone beyond all of their waivers. Other states, tied their waivers to the end of the federal PHE. So
but then others have actually adopted their waiver as a part of their state plan amendment and submitted it.
Yeah. As they say, there's not a Medicaid program. There are 56 Medicaid programs, as they say. So. And some of you I know not only are dealing with Nebraska Medicaid, you may be dealing with Wyoming, Missouri, Kansas, South Dakota Medicaid, which always makes it even more interesting.
Any other questions related to the end of the PHE for Marty or for Kathy? Okay, I think Marty, you overwhelmed everybody a little bit.
I'm sorry, I apologize.
No, it's all good. So, well, thank you very much, Marty. We have about 15 minutes remaining, and we like to open up the end of these calls for just open discussion related to any compliance related issue or question that anybody might have. This is your opportunity to ask a question or bring up something with your peers. And so we would encourage you to do that. Again, chat box, or feel free to ask your question live. Looks like, can we talk brief? Oh, I lost it. Can
Yeah,
we
I
talk-
saw it. Can we, the JW and the JZ modifiers, and doesn't apply to critical access hospitals? The answer is yes. The JW, I've got to remember this correctly. JW has been there for a while and has been applicable to critical access hospitals. JZ comes in this fall. I think it's this fall. It's either July or October, and that will then become applicable as well. This is on the whether or not you wasted any of a single dose drug. My gut reaction to this, and I think it's worth commenting in the outpatient rules, is that, and I just got to, can you give us a reference? I can get you the reference because someone actually gave it to me, so I will look for it real quick. But it was the issue related to those modifiers. When JW means that you've wasted drug out of a single dose vial, you would think that if there was no modifier, the answer would be I did not waste anything, but that's not, they want a modifier no matter what. So I am looking for that reference related to JW, and because someone actually sent that to me last year when we did some presentations on this.
While you're looking for that, Kathy, we had another question about the 340B modifiers. Will they relate to critical access?
That I do not know. I'm glad to research. Susan might know. Is Susan?
Yeah,
Oh,
I don't know the answer to that. Apologize.
JZ, JW, and then the 340B modifiers. I can look it up and get you some info. John, I will get back with you on that.
Okay. Other questions?
Kathy just says, I think I found it. Kathy, what'd you find?
Kathy, we'll give you a second. Okay.
Yeah, I think I found it, Kathy, and I think I'm the one that actually.
I was going to say, I think, I mean, it was either you, someone from this group or someone from Montana, and you did have something.
Yes, I found it. Do you want me to send it to you again?
Can you read it for
Well,
everybody? And then yes, send it to John and to me.
Okay, I'll open the link right now. It's from an FAQ.
Always a great source of reference.
In which settings is a billing provider required to use the JW or the JZ modifier? And the answer, there's a wordy answer, but the last sentence that says the JW and the JD modifier requirements also apply to critical access hospitals since drugs are separately payable in the cost setting.
Perfect.
And we did have somebody share that in the chat, the link to that PDF as well.
I really appreciate the fact that y'all are so willing to do this and to share this information.
Yeah, certainly helpful. Other questions, comments anybody has?
I assume that we still have the question on the modifiers for 340B for cause.
Yes, unless
Okay.
somebody in the group knows that information. Not sounding like it. So we will get an answer to that for you. Other topics, anything anybody would like to discuss?
So I did find some information on the 340B modifiers. So
Okay.
there's two of them. JG, which is a drug or biologic acquired with 340B pricing. reportable for informational purposes. And then TB is a drug. Oh, this is wonderful. A drug or biologic acquired with 340B pricing reported for select entities. Let's see. Looking through here for a cause, they are supposed to report the TB modifier for drugs acquired under the 340B program. And I can, John, I'll send you that. This is from CMS, so I'll send you this this guidance.
Actually, if you can put the link in the chat, could you do that?
Yep.
Great. And I will send these links along with the handouts from today as well. So great. Any other questions or things that anybody would like to bring up today?
I just wanted to mention one thing because I know some of y'all might operate a skilled nursing facility or have swing beds. But just wanted to share that on that open door call that Marty mentioned, the skilled nursing open door call, one of the things that they, in addition to talking about when does the 3-day prior stay actually go into effect, admissions on or after May 12th, they raised the issue of the skilled nursing interrupted stay policy. The interrupted stay policy essentially means that if you leave a SNF for no more than 3 days and then return to the same SNF, that it's considered a continuous admission. What they explained, and it's like, okay, this was an hour-long webinar that lasted about 25 minutes, and then everything else was people asking, did you really say on this one particular issue? It seemed like every other person had this one question. If a patient was admitted prior to May 12 and they leave the facility after May 12, come back within 3 days, and they are readmitted to the same facility, they do not need to meet the 3-day prior stay because it was waived during the point of time that they were initially admitted. If they stay out longer than the 3 days, or they are admitted to a different skilled nursing facility, then they are going to have to meet the 3-day prior stay in a hospital setting before they could be in a covered SNF stay. So it's a question of how long are they out and were they readmitted to the same facility or a different facility?
Great. I just had a housekeeping announcement I wanted to make, but again, if you have a question, feel free to drop it in the chat box or let us know. Our next roundtable call will be on June 12th, same time as today, so 1:30 to 3:30 Central. And we are planning on an in-person meeting, a full day meeting for this group on September 18th. That'll be in Lincoln. So we'll have more details about that coming out, but we will be sending out a survey to all of you and all of our compliance officers across the state to get feedback on what topics you would like to have for that particular day. So please complete that, share those thoughts with us. We have a planning group that gets together and we'll convene to go through those and find facilitators to lead those sessions, but we are very excited about having a full day with all of you, and again, giving you that opportunity to get together with your peer groups. So watch for more details on that.
And if you want to present,
certainly,
we'd love to know. We'd love to have some of y'all present.
Yeah.
And then I want to say kudos to Susan Thomas for what you just posted in the chat, Susan, because that was just issued on the 3rd of this month.
Yeah.
Good find.
Yeah, pretty fresh off the press.
All right, well, don't see any more questions coming in, but certainly, again, I thank everybody for your time today. We always find these roundtables so valuable, and really appreciate everybody participating and asking great questions. And thank you, of course, to all of our facilitators today for providing such great information to us. So we will look forward to talking to you again on June 12th.
Take care.
Thank you.
everybody. Bye.
Thank you.